Just to chime in, thank you, Michelle. We will have a showcase before we start, a sponsor showcase at 1:05. That's in about, 1 minute. And then we'll move right into session 2. I will introduce you. I will be your moderator, and I will introduce you. I'll manage questions that show up in the Q&A box as well as in the chat box. And I have a feeling that the next 55-minute session is going to be a pretty dynamic one, as was the first one that we had today. This is an exciting topic that is near and dear to my heart for a number of reasons, which I'll mention on mine. But for now, let's go ahead and get ready to tee up the sponsor showcases if everybody is ready. This is Exact Sciences. They are one of our sponsors. We appreciate their participation in this particular program as well as in this particular session. Exact Sciences is sponsoring a great new project, one of our sponsors of a new project that we're just launching on the very topic that we're going to talk about today. So I'll get into that in just a second. So with that, if we can take a look at, I think it's a video. I love these videos.
I was probably in the best shape of my life when I turned 50. I'm a vegetarian, I'm a runner, I'm a very healthy person. My doctor told me that it was time for me to get a colonoscopy. Colon cancer was not on my radar at all. I didn't want a colonoscopy. Come on, let's go. It just seemed like a lot of work for them to find nothing.
35% of the people have been telling us for years and years and years, I'm not taking a day off work. I get a colonoscopy.
I didn't think it was right for me.
You have to offer those folks another option.
With Cologuard, we can accurately screen for colon cancer, looking for cancer DNA in the patient's stool sample.
What caught my attention is the fact that it can be done at home.
It just sounded very easy, that there was no prep, there was no dietary changes. I got my kit in the mail. So I did it and I sent it off, and about 2 weeks later I got a call from my doctor telling me that my test came back positive. Imagine my surprise when I had the colonoscopy and it turned out I had colon cancer and that I would need surgery. I had a tumor. It was very small.
The hope is you catch it early where it's much more treatable.
If you find colon cancer stage 1 or 2, 9 out of 10 people survive. If you find colon cancer stage 4, 1 out of 10 people survive. The whole goal is early detection.
I turned 50 in August. I took the Cologuard in November, and I already had cancer. I had my sigmoid colon removed. The early detection got me to avoid having to go through radiation, having to go through chemo.
When you're 50, you should be getting screening. You shouldn't wait until you're 53.
The longer you wait, the more time it's had to grow. I went and got screened, and thank goodness I did. I'm cancer-free. Life is good.
Cologuard is for adults of either sex, 50 years or older, who are at average risk for colorectal cancer. Cologuard is not a replacement for diagnostic colonoscopy in high-risk individuals. Talk to your healthcare provider about Cologuard. Cologuard is available by prescription only. Both false positives and false negatives do occur. Any positive should be followed by a diagnostic colonoscopy. A negative Cologuard test result does not guarantee absence of cancer or advanced adenoma. Following a negative result, patients should continue participating in a screening program.
Very good. Thank you to our friends at Exact Sciences for participating in this. Bill Stafford and Gary Greinke, we appreciate your support. Now let's get started on this next session. As I said, the topic is COVID's impact on delayed cancer care on employee health as well as on healthcare costs. Why is that? Well, cancer is expected to kill 42,840 Texans this year, 2021, according to the American Cancer Society, and an estimated 134,000 new cases in Texas are expected. Unfortunately, cancer screenings and treatments saw a sharp decline during the COVID pandemic. There were delays and disruptions in cancer screenings and care delivery, coupled with the fear and avoidance by those who are at risk for cancer. And these problems will likely lead to greater severity, more complications, worse outcomes, and higher healthcare costs. So we decided to do this session for a couple of reasons. One is employers are concerned about the fact that the screenings have dropped dramatically. We're in the process of doing a survey right now of our employer members in the Dallas-Fort Worth area to find out just how great of a difference between 2019 and 2020 is the decline in breast mammograms and pap smears and prostate tests and lung screenings and colonoscopies or Cologuard, as you saw in the Exact Sciences video. It will be interesting to see how dramatic the decline actually is in our particular market in Dallas-Fort Worth. But more importantly, we need to really understand how to encourage these cancer screenings among the employee population and how to design benefits to make sure that, or to encourage these screenings. So with this session, we're honored to have 2 cancer care experts as our speakers, plus an employer who understands the importance of cancer screenings and has actually put in place some really innovative benefit strategies to encourage the different cancer screenings. I'm so pleased to introduce Dr. Deborah Patt. She's a practicing oncologist and breast cancer specialist in Austin. You probably don't need to read through all the tiny print here because you'll have access to these slides afterwards. But she's also the Executive Vice President of Texas Oncology with responsibilities in healthcare policy and strategic initiatives. She does breast cancer research in Austin and leads a multidisciplinary tumor boards for breast cancer. She, with the Texas Medical Association Council on Legislation, she formulates responsible healthcare policy that improves the health of Texans. And on, but she's also a clinical professor at Dell Medical School at the University of Texas at Austin. And Dr. Patt has performed in 2 of our cancer care theatrical productions that we've done over in 2016 was the first one, and 2019 was the second one. And I don't know which is she's more apt for her career, whether it's practicing oncology and breast cancer treatment or being an actress. She's just super at both of those. So thank you for joining us, Dr. Patt. I also would like to introduce Dr. Todd Sachs. Dr. Todd Sachs leads Access Hopes, which is another one of our sponsors, clinical team, and oversees the remote delivery of cancer support services. Before arriving at Access Hope, he was the Executive Vice President of Corporate Development and Finance for the Permanente Federation and has worked with Kaiser Permanente's Southern California Permanente Group with broad governance and documentation and coding. And he also started Kaiser Permanente's bariatric surgical program in West Los Angeles and continues to practice surgery. His specialty is endocrine surgery of the thyroid and parathyroid glands. So welcome, Dr. Sachs. And then David Hines, he is the Executive Director of Employee Benefits for the Metro Nashville Public School District. He started his career at Blue Cross Blue Shield of Tennessee in claims management, moved into Director of Operations for the state of Tennessee Employee Health Plans, then Benefits Manager for Nissan Motor Manufacturing, Benefits Consultants, Insurance Director for Rutherford County, Tennessee, and now he's with Metro Nashville Public School District with a long lineage of working in benefits. So he is going to give us some real insights on the role of benefits in encouraging the cancer screenings and taking advantage of the care of early treatment. So with that, I think Dr. Patt, you will start off with some of your interesting findings.
Great. Thank you so much, Marianne. It's odd, I know that we're here on Zoom together. I appreciate that time. As we have, as Marianne mentioned, we've been in a performance before characterizing cancer care, so this doesn't seem all that odd. Well, I appreciate everyone taking time to talk about cancer care today and how it's altered during the COVID pandemic. I'm sure as employers, you all have been challenged in the most difficult ways to try to support your workforce, to try to support our patients, your employees as they pursue health during this most difficult time. It's posed new challenges in managing a workforce that may be remote, trying to manage accountability, mental health, which has been a recurring issue, overall wellness, sometimes childcare issues. So there have been a lot of changes that we've had to manage. It's not surprising that some things that we think of as preventative care has sort of taken a back seat. And we as oncologists in the state of Texas recognized that there was a change that we observed in cancer care during the beginning of the pandemic. And so we sought to understand it better. So what I'm going to present to you today is a study that we did. I serve on the board of the Community Oncology Alliance, and we worked with a group called Avalier Health. We queried the Medicare 5% population, about 6.2 million Medicare beneficiaries, to try to understand utilization of cancer tests between 2019 and 2020. Screens that would diagnose cancer early, biopsies, surgeries, and ultimately chemotherapies, to try to understand how the COVID pandemic was impacting utilization of cancer services. As we know, in the words of one of our founding fathers, Ben Franklin, an ounce of prevention is worth a pound of cure. So it does start with screening. I was so happy to see the Cologuard advertisement. Actually, there's an internist from Austin, Anas Dagestani, who helps to lead Austin Regional Clinic, a wonderful multi-specialty practice here in Austin, talk about that, because I do think we need to heighten awareness for screening. So, the natural consequence of delays in care is that cancer continues to grow and remains undiagnosed. I'm certain for anyone attending this meeting that that's happening with some of your employees today. And I'd love the opportunity to talk to you about why. So this is really a claims analysis where we looked at claims from the Medicare 5 to 7% population. What I'll show you is 2019 versus 2020, looking at January through July. So we could look at utilization characteristics during that time frame. Can you go to my next slide? What you can see here, if you looked at just regular E&M services, so this is how many times did cancer patients see the doctor for cancer care during March, April, May, June, and July of 2020 in comparison to 2019. And this looks at new patients, established patients, and then hospital outpatient departments for cancer-related services, 2019 in comparison to 2020. And what you can appreciate is that there is a substantial decline seen in March, April, May, June, and July. And we've now have this data and follow up through November, and it looks much like July, that there's a substantial reduction in visits with their doctor. We know that's important because if patients aren't seeing their doctor, they're either not having their cancer diagnosed, as you can see, new cancers or visits are down, or they're not being treated appropriately. Next slide. So this looks at change in billing frequencies related by site of care. So knowing that the COVID pandemic largely hit hospitals, we were interested if private practices or professional practices were different than institutions. And what we saw was that that was a little bit different in billing frequency delays or decreases in 2020 in comparison to 2019 by site of service. That it seemed that offices were hit a little bit less than the hospitals, the private clinics. And that makes sense because the hospitals have been managing COVID as it's come into the hospitals when patients are hospitalized and go into the intensive care unit. Next slide. And while telemedicine has been a tremendously useful service to patients during the pandemic, it's really been the silver lining of the pandemic. And I think much like virtual working will forever change care delivery, telemedicine visits were not enough to make up for the gap that exists in care delivery. So what you can see here on the left side is 2019 visits. And on the right side of each of these bars is 2020 visits. And the gray bar represents telemedicine visits. And what you can see is that telemedicine, while it did play an important part of closing some of the gap still was quite wide open in how cancer patients engaged with their practitioners. Next slide. And this just looks at differences in telehealth between institutional and private practices, really that private practices engaged the large majority of telehealth services across the country for Medicare beneficiaries. Next slide. So this looks at cancer screening, and this is what I really want you all to pay attention to, because this is where it starts. Again, an ounce of prevention is worth a pound of cure. If you look here at the blue mammograms, the orange colon screens, the gray lung screens, and the yellow prostate screens, what you can appreciate is that March, April, May, June, and July, there were substantial decreases in all screens for cancer. The natural consequence, of course, of patients not screening is that they won't diagnose occult cancer. So they won't be biopsied for adult cancer. They won't have surgeries for occult cancer. And they won't have the opportunity to have early detection for occult cancer. So we can anticipate, and certainly anecdotally, I observe in the clinic that the natural consequence of patients delaying their screenings is that they present with later stage disease. And I'm sure that you are aware of that as employers, as business groups. Certainly, I appreciate that in the clinic, because I've seen more patients with advanced cancer diagnosis in this year as a result of the absence of screening. In fact, I'll say I had a new breast cancer patient in my clinic yesterday who has a locally advanced breast cancer who will require chemotherapy. And she said to me, you know, Dr. Pat, I totally forgot about screening in 2020, but I went to go see my primary care doctor, and she said, you know what, you really need to get your screen. So I got it, and sure enough, she had a breast cancer, not a palpable breast cancer, so it was occult, but diagnosed by screening. So what we see is this dramatic decrease in cancer screenings. Next slide. And then similarly, if you're not having screens, you're not finding occult cancer, so you're not having biopsies. So if the rate limiting step there is screening, if you're not screening, you're not biopsying. So this looks at biopsy frequencies of breast, colon, and lung for March, April, May, June, and July of 2020 in comparison to 2019. And you can see that they are dramatically down. Next slide. This looks at reductions in infusions, and you can see that there are substantially reduced infusions during this time, which probably represents decreased services for people with established cancer diagnoses, and also a decrease in treatments because patients are having delayed diagnosis. Next slide. This looks at cancer-related surgeries. So again, if the usual process workflow is you screen, you biopsy, you diagnose a cancer, and then generally you operate on a cancer. What we can see is that cancer surgeries were down substantially during this time, and it lasted from March through July and still through November, that it's been substantially decreased. I think this is multifactorial in my opinion. Not only is it that the upstream lack of biopsies and screens led to decreased surgeries, but also as the hospitals became full with COVID patients, some surgeries were delayed or detoured during the pandemic, particularly during peak months like April and July in the winter, and again just recently. Next slide. So we put together this graph just to try to understand how this correlated to the 7-day moving average of COVID. So what you're seeing here in the gray is the 7-day moving average. That's the area under the curve of COVID across the country. And so, and it looks very similar across the country as it does in Texas. And what you can see is that the rates of screening are inversely proportional to the rates of COVID. And when we have lower cases of COVID, the screening tends to improve. So I think I would leave you with a couple of thoughts about this. One, again, you're managing a workforce with many new and very challenging demands. You're managing their working from home, their mental health, how they're accountable, their wellness, sometimes childcare issues. It's my belief that patients have many reasons why they've failed to participate in regular and preventative health care. Some of it is based in fear, as Marianne alluded to at the beginning of this, that people are fearful of going to the doctor, especially early on, fearful of going to the doctor. Maybe they have transportation issues. But what we're encountering now is that there is limited capacity to do some cancer screenings. Certainly it's true for colonoscopy. Certainly it's true for mammography, because there's such a backlog. If you're going to have social distancing in a clinic, there's only so many that you can do. It's one of the things actually that makes Cologuard such a nice option for colon cancer screening. And so those things remain challenges. And then if you think about the burden on your employees, the burden on employees today is not only that they know that they have forgotten or neglected their preventative services, but also that they're busy managing the many competing priorities that COVID has caused to emerge in their life, whether it's bills that they have to pay, whether it's managing a change in their work life, whether it's been managing the mental health or physical health of a family member, or even the education or childcare of their family. There are many new burdens. And so when you have a slate of competing priorities, frequently screening gets pushed to the wayside. I would challenge you all to champion screening among your employees, because at the end of the day, it saves lives. And again, as a community practitioner, I observe the natural consequence of this today as I see patients present with advanced cancers, and would like to see that change, because I know that if I diagnose cancer earlier, their treatment is less complex and they're much more likely to be cured. Thank you.
Oh, thanks. Thank you very much, Dr. Pat. Let me turn my video back on, Michelle. Okay. Now, what I'd really interesting statistics on what Dr. Pat is describing, and it has a lot of relevance to the project that we're launching in the Dallas-Fort Worth area on the impact of COVID on delayed care, which I'll talk to you a little bit more about. But what I'd like to do is hear from Dr. Sachs and with Access Hope, as I said, one of our sponsors, about some of the things that you're doing after someone has been diagnosed with cancer and then has to go find a place to go and get treated and go through what the process, the cancer care journey, as we call it, and as our two theatrical productions focused on all the different stages of the cancer care journey. So with that, Dr. Sachs, it's all yours.
Thank you, Marianne, and thank you, Dr. Pat. That was really informative. And I want to thank also the Texas Business Group on Health for having me here today. I really appreciate it, because I'm passionate about the topic I'm about to talk, as is the organization that I represent. And that's helping more people gain access to better healthcare, especially when diagnosed with cancer. But if you don't mind, I'll take just a second to give you a little bit of background about Access Hope. If we could go back to that first slide. Access Hope was founded by the City of Hope, which is, many of you may recognize that name. The City of Hope is based in Southern California, just outside of Pasadena. And it's one of the most respected cancer centers in the world. What they wanted to do is they wanted to bring that high-level cancer expertise to more people, no matter where they live, regardless of their zip code, or as we like to say, democratizing cancer care across America. And so they created Access Hope about 3 years ago. And what we do is we work directly with employers to help connect their employees to these high-level specialists at City of Hope, at Northwestern's Medical Lurie Cancer Center in Chicago, and Dana-Farber Cancer Institute in Boston. And in the near future, we'll probably have a few more that we will identify as well. So with that as a little background, next slide, please. I'd like to talk a little bit about just disparities in healthcare. As you all know, health disparities and inequities really refers to the fact that groups of people in the United States receive different levels of healthcare. A very straightforward example, of which I've experienced multiple times, is just language. When we as physicians don't provide health information in a language that someone is fluent in, you increase that potential for negative impact to their care as well as their outcome. That same thing goes true in terms of if they're not comfortable with technology or unfortunately have a lower educational level. And specific to cancer, there's a lot of disparities. Overall, the incidence of cancer and mortality in the US population in aggregate is declining, which is good. But there's certain groups where they continue to be at a higher risk of not only developing, but dying from particular cancers. And to give you a couple examples, for African-American males, they have a 111% increased risk of dying from prostate cancer as compared to their Caucasian counterparts. In African-American women, 39% are more likely to die from breast cancer than the Caucasian counterparts. And when you look at heart disease, we all know that that is the #1 cause of death for Black and white populations, but that's not true when it comes to Hispanic populations where cancer is the leading cause of death. And there's also other differences when it comes to income level and even sexual orientation. Next slide, please. I really appreciate what Dr. Pat was informing us of. You know, I've seen it firsthand how that there's been a negative impact on health outcomes due to the delayed cancer screenings. This article caused me a little bit to jolt when I saw this in JAMA last year. And it highlights just a little bit what Dr. Pat was talking about with advanced cancers. So you might look at this slide and say, well, these lines from the top to bottom all seem about the same. It doesn't seem that different or impactful. But what those lines are outlining is time delay from getting those screenings, from just a few days all the way up to a full year. But what's really impactful is when you have an advanced stage colon cancer that hasn't been detected and you get a screening, every 2-month delay has an associated 3 to 6 increase in your 5-year mortality, the risk of dying. That was very, very concerning to me. And I'm sure to all of you as you hear it. We really do believe that advanced cancers and complex cancers should be best treated by highly specialized oncologists like Dr. Pat and others. And we know that the outcomes will change, and I'll show that in a few moments. But the question is, what if you don't have access to that highly specialized team? Unfortunately, a lot of Americans don't. So if you wouldn't mind going to my next slide. It's about geography, where someone lives. It's one of the most significant determinants of healthcare disparity in the United States. You know, 20% of the United States population lives in what's known as rural America. That's actually now more than, not almost, but more than 60 million people. And rural communities is defined as, and not my definition, this is the US Census Bureau's definition, is any community that's not part of an urban community of 50,000 or more people. You know, most of the time when you're in one of these rural communities, you don't have that same level of access to care like you have in Dallas-Fort Worth, or I have in Southern California. And also what is unfortunate is these communities often are marked by a significant burden in health disparities like obesity, diabetes, hypertension. So the point really is that someone who doesn't have easy access to this high quality care is really at a disadvantage. Next slide, please. So here's a depiction of geography and the impact of health disparity. The light blue dots represent cancer centers and the purplish dots represent NCI-CCC centers, National Cancer Institute Comprehensive Cancer Centers. Those NCI-CCCs are really felt to be and recognized as the gold standard when it comes to cancer care. They're the places that are advancing the cancer research. They're the ones that are creating the guidelines, reviewing them, and those guidelines can be changing 2 to 4 times per year. They're the ones that are knowledgeable about the innovations, and they're often staffed with highly specialized physicians. But what's interesting is that you find that there's only about 51 or so NCI-CCC centers across all of America and in 29 states. And so if you look at this map, you can see large areas of this country where people live far, far away from those centers. And even in some places where you have those centers in your state, let's look at Texas. For example, there's 2 in Houston, 1 in Dallas, a center in San Antonio. But if I did my distance calculation right, if you live in El Paso, you could be over 500 miles away from one of these centers. And in fact, when you also look at the aggregate in terms of the United States, only 20% of people are actually taken care of by these highly specialized physicians and centers. So I think the question that you might want to ask yourself is, does this access to this type of level of care really matter? Next page, or next slide, please. And I would say it's a resounding yes. So here from the JAMA article from Oncology, if you look over to the right, when you look at all community hospitals and the all 5-year survival for when you aggregate all the different type of cancers, the 5-year survival is about 44%. But as you move from right to left, when you look at the cancer centers and those treated at NCI CCCs, that increase in survival goes up from 5 to almost 10%. And unfortunately, that gap can be widening. So let's take a look at why that gap may be widening and how we may close it. Next slide, please. So the reason that we feel that there's some differences in treatment is really just because of the sheer volume of new information, new innovations that are coming by in treating cancer. As I say that, that's a wonderful thing, right? Because we're starting to understand it better. We're understanding the nuances. We have additional treatments that we can provide beyond chemotherapy, such as immuno-oncology, cell therapy, next-gen sequencing, et cetera. We have to remember that cancer is not just one disease. There's over 100 different types of cancers. With the amount of information changing now on average in cancer every 73 days, think about that. That's just a little more than 2 months. It's hard to stay on top of all of the current information, and that can lead to gaps. You know, when I trained back in the late 80s and then went into my surgical practice in the 90s and currently, it was a one-size-fits-all. What's nice is that that no longer pertains, and we're trying to do more precision-based, personalized-based cancer care. And so what happens is that oncologists, not everyone has that opportunity to specialize in their care. They have stated with working with us that they appreciate the opportunity to be supported and work collaboratively with the experts that are part of our organization in Access Hope. And in fact, 4 out of 5 oncologists have noticed and stated that they're not completely confident when when delivering precision medicine. So next slide, please. You know, within Access Hope, we feel that we've created a mechanism to bridge this geographic gap, as well as the knowledge and the outcome gap that's been created thereof. So we're here to deploy the latest cancer expertise, knowledge, research, innovation to places and people where it's needed most and when it's needed the most. We feel that's right up front when someone's diagnosed, and we're helping the patient, and we're working in collaboration with the local oncologist. The local oncologist has that opportunity to be connected to these experts at City of Hope, Dana-Farber, Northwestern Medicine's Lurie Cancer Center. And unlike the historical Center of Excellence model, which really is asking the patient to come to us and we'll treat you here, our model is different. Our model is where the patient is right there, never leaves the side of their local oncologist, the person they know well and trust. They don't leave their home. They don't leave their support system and their family. And that's how we feel we're bringing that expertise of some of the best cancer specialists in the world to where people live. And that's also how we feel we're slowly chipping away at those healthcare disparities that I mentioned earlier. So slide, I just want to conclude this by saying thank you. I really appreciate the opportunity and thank you for your attention.
Yeah, very, very interesting, Dr. Sachs. I thought the most interesting, I mean, kind of the scary part of this is about the geography and you know, the access to care because, based on geography. I'm thinking of the rural worlds or all those states that didn't have any of those cancer centers of excellence. But I do want to come back to that with you, Dr. Pat, and talk about the Community Oncology Alliance, which has a tremendous role to play in access. But let's just wait for a second and hear from the employer's perspective on the impact of delayed care. David Hines, you are kind of a leading light out there for the screening side, getting the early preventive and early diagnosis to be so well used by your employees. What's your secret sauce that you're using? And tell us about how you approach this.
You know, the secret sauce, it actually ties into a lot with some of the stuff that you're already talking about today when you talk about this advanced primary care and the different issues. But let me kind of dive into it. If we'll hit the next slide, a little bit about the folks I get to work for. I'm proud to be able to take care of our teachers. I work for the school system in Nashville. We have about 6,500 active and teaching employees and about 4,000 folks like myself, which are support staff. I've got this odd situation, the fact that I'm not on the health plan that I manage. There's a dividing line within Metro Charter that says that, you know, Metro Employee Benefit Board takes care of benefits for everyone except for those with a teacher's pension. And so I have a unique group and a unique opportunity as I focus in on taking care of teachers. So when I'm talking today and the steps that I am focusing on this one group of folks. Yeah, like I say, it's about 6,500 active teachers, about 3,000 retirees, a couple thousand of which are on Medicare. And you put that together with the dependents, about 18,000 covered lives. And we do have this core belief, as I went in and I started talking many years ago, that we should focus on the health of our employees, because you know what, in the long run, healthy employees are better employees. They're also cheaper employees, you know, if we can focus on health first. And instead of worrying about copays and structures like that. Next slide, please. Our approach is very basic on what we do, basic but aggressive. I tell folks I do believe in choice in healthcare. I give you one plan to pick from. You can take it or leave it. That's your choice type situation. So we provide everybody, since we're in one urban setting, there's not really a network difference. So it's one simple low-cost health plan. You know, I still have a $300 deductible and a $2,500 out-of-pocket max on this plan. And so we keep it very simple. I do believe very much in data. We pull in all our health claims data along with pharmacy, along with time and attendance, payroll information, EMR, health risk assessment, you name it, we pretty much bring it in so we can look at it to help understand what's going on with our population, see how we can better address it. We do have a focus on primary care through our on-site health centers. We've been doing it over 10 years, and it is full primary care at no charge to both the employees and their dependents within that. Value-based benefits, giving away primary care is part of it, but we also give away a lot of other things. We give away diabetic drugs and supplies, asthma, COPD medications, cardiovascular medications. And then here lately, I've been doing a lot of value-based bundles from maternity care to hip and knee surgeries to gastric bypass. So it's we give away or promote things that we believe we need to emphasize and work on it. And then I've got a group of folks, and I have somewhere around 80, 90 folks working in our on-site medical centers and folks that focus on our populations being headed by our doc, Martha Shepard, whose main job at the patient she sees is the entire population as we work to try to close gaps in care and improve the overall health of our population. Next slide. This is just a picture of where we started from. We actually took classroom portables, remodeled them, set them across Nashville, Tennessee, 15 minutes from any work site, no more than a 15-minute wait. As I mentioned, we started over 10 years ago with this basic structure, and you can fit 4 exam rooms, a very small waiting room, a nice lab, a nice handicap restroom, and a provider office in these. And that's been our core structure, which led us to the next facility. On the next slide, please. 2017, we're able to bank the savings that we're able to generate in decreasing the overall healthcare spend. and moved a couple of our facilities, moved away from a portable at one of our areas. So we built out a 26,000 square foot integrated employee health care center, or wellness center. This facility not only continues to provide the primary care, but it has physical therapy, occupational therapy, it has chiropractic and acupuncture, we have fitness specialists. There was some discussion earlier about mental health. We have 2 psychiatric nurse practitioners. We are pushing to get another one, and most of their work is now moved to telehealth and not coming back to face to face. It's probably going to stay with more of a limited telehealth president and a predominant telehealth and a limited physical telehealth, physical, visits. Getting tongue tied here. But we also have the pharmacy, fitness, floor, and facility health coaches. And so it is a true integrated thing. And the providers are able to work with each other. Chiropractic and acupuncture work with each other. Primary care can reach out to the mental health providers and the other folks for assistance. And even the PT and the different folks, we see them working their patients out onto the fitness floor to continue their episodes to improve their overall health. So it's been a great thing. Next slide. We do work in cooperation with Vanderbilt Health. We utilize them as the manager of our folks, and we are very much what's considered patient-centered medical home. If we're truly going to see changes in our population, if we're going to see changes in the way care is delivered, we have to move away from what is today kind of a provider-centric. You show up at that hospital, the provider on their schedule, in their locations, to getting more patient-centric, which is basically now the world revolves around you. We have to become more the Amazon Prime delivery of healthcare, somewhere along this transition that we're going. So it is patient-centric. It's looking at data and using the data sets. It's identifying gaps in care and working through that. It is setting up teams that work together, and we focus on trying to improve the health and the life of our members. Next slide. A key component of being a patient-centered medical home is quality improvement. You're always pushing to move forward and succeed. Now, I was very happy as I sit there. I get data from a lot of different places. I have our data warehouse. We have our EMRs. We have Cigna as our TPA. When Cigna sat down with us earlier this year and talked about where we were on preventive screenings and such, year over year, we actually did not show a reduction in our screenings last year, because when everything shut down, our providers didn't stop working their populations. We had well visits, we did outreach, we identified the gaps, and as you can see, where we're sitting against our goals in July 2021, about 68% on breast cancer screening, cervical cancer 76, colorectal screening 76. You know, those are the cancer screens we're talking about. As you can see, we're still have a little bit below our goals in diabetes, but it's taking the time, it's getting the data, and it's reaching out to people, and then being creative about some of the things you can do. Next slide. One of the things we found as a great success has to be, what we call our mammoglam parties. It's taking a mammography, making it a fun social event. Our teachers love it. I mean, you look at my employee population, it's 79% female. What we've seen, we can go out, and we've worked with 2 different hospital systems so far in this thing in setting up these things. We go and we basically have a Saturday. They will book out the imaging department, bring their staff in. We get somebody to sponsor, since the medical facility itself cannot incent people to come and have care, but we want to incent people to come and have a good time. Before COVID, we would have mani-pedis and different things going on, massages. Now everything's half off, so there's cupcakes and goodie bags, and our staff come in. We've had over 70 women come to these events. We're about to have another event here this month. We had slots for 68 folks. The 68 slots have been taken, and there's a waiting list on top of that. But you can take something that's not fun and make it fun type situation. And then you've got a lot of folks that are very invested in some of the outcomes. One of the ladies in this shot's one of our nurse practitioners who is a breast cancer survivor herself. Wanted to be there to take time to encourage the screenings and work with the folks. And so there's an investment, and there's teachers bringing other teachers. And what's the neat thing is we're getting a lot of folks that are showing up for the first time as their peers are bringing them along with them in order to be screened. Next slide. Another thing that we do is understanding this dynamic that we have of being a medical home, and also understanding our membership and our patient population. And so we've set ourselves up to be out front on women's health. Trained our providers to work things out. So when it comes to issues like cervical cancer screening, we've been able to push and move forward and try to get the people. There's a lot of messaging, a lot of dynamics that go through into becoming more and more accepted by the population in order to be that friend that assists them in their medical journey. Next slide. Another great thing is always run campaigns. We refresh and fresh. If you don't know that 45 is new 50, I noticed the Exact Science presentation that they did early talked about this lady getting screened at 50. Well, 45 now, folks, is the new 50. We should be starting to get screened out. And you know what? Nobody wants to go for a colon cancer screening. The colonoscopy is not a fun event. And so we have embraced the little guy in the blue box. It's on the next slide. Cologuard is a great option. It's the cost is reasonable. It goes to the home. It can be done at their own time. One of the things I would encourage you, if you promote Cologuard and there's employer avenues, is Cologuard will actually, Exact Sciences will work with you on a promo program. We've worked with them and we've done several different rounds of this. It's it works well. It goes to the home. There's little cost. Make sure though you modify your benefits to pay all colonoscopies at 100%, because what you'll find is if you come back and you have a positive in Cologuard, then you go to the colonoscopy and we have this issue of something being diagnostic versus preventive. Most benefits are set up to pay preventive colonoscopies at 100%. But if it becomes diagnostic, if you know there's an issue, then all of a sudden it's subject to deductible and co-insurance. I had teachers, educated individuals, making a reasonable salary, sitting there and not taking the next step to get their colonoscopy because of the cost, the out-of-pocket cost that was going to cost them around $400 in order to further diagnose and find their condition. So Cologuard's a great option. It's easy, it's well accepted. We've had, as I mentioned here, about 272 people screened, have about a 10% positivity rate. We've saved lives in this process. So, and they're in the classroom. A teacher's not missing 2 days out of the classroom, that wonderful prep day and that wonderful days of having the colonoscopy itself to do that. So it's a great thing. And anytime we do something like that, we always look for testimonials and results. And next slide. Because it gets back down to the real life stories. I look a lot at data, but it's wonderful to have the examples. We have Julie and Art, married couple. Julie's our employee. She's an art teacher and her husband's art. But anyway, it's they did the Cologuard test together. She was fine. He wasn't. And basically says it saved his life. And so this is what it really comes down to. Real quickly, I know time's getting long. I just want to point out a couple things real soon, since you guys are talking about social determinants of health a little bit. If I can see that next slide. Nashville, Tennessee is supposed to be a healthcare mecca. And yet this is actually a graph we had from Cigna. And we pinpointed our healthcare centers on there as the stars, but over half of our folks live in areas that have low resources when it comes to basically healthcare and the social determinants of health that we're talking about, where the other half are in good, relatively affluent areas. And it goes by racial lines. Even though I have a salary set Everybody's getting paid the same. You still find predominantly my black, my white, my brown populations all living in different places. What's been great is the fact that my clinics have been located in areas that have low resources. Next slide. What I found within my group, and this is neat because I actually take ethnicity data out of our HR system and lay them in so I can talk about what's going on with my employee population. You know, about 69% of my population is white, 25% black, and 6% is other, which is predominantly Latino, followed by Asians and such. Average age is about 42. Next slide. What we've been able to see is basically my black populations have attached to our clinic as their medical home in a greater percentage wise than any others. My Latino or other group is as well, but as you can see, 48 for black, 44 for white, 47 for other versus the other group. What we have an issue is, especially within the others, is the fact that there's a higher level of medical homelessness that's going on there, where they're not basically attaching themselves to primary care. Next slide. And as a result, especially with the other group that's predominantly Latino, in here, the lower the number, the better, because we're looking at gaps in care. What we're seeing is very high gaps when it comes to cancer screenings, be it breast cancer, cervical cancer, or colon cancer. What is great on us is you can see my black population, which is very attached to our clinics, are actually getting the greatest screening rates. They are the fewest gaps in care. Next slide. And that's it.
Wow, that was quite a presentation, David. Thank you very much. I mean, I got a gazillion questions, and we are running short on time. One key question I have for you, David, is you mentioned that you have an integrated data warehouse. Is that with Cigna, or is it your in-house one? And the reason I'm asking is, how easy is it for you to get the data, which you have wonderful comprehensive data on, demographics, on utilization and everything? How easy is it for you to get that?
You know, I've been doing this a long time. The data is not with Cigna, but Cigna is obligated to give me my feeds. In fact, one of the things you have to do is start in the RFP process and basically write in there where you want to go. I make everybody obligate themselves to give me my information in the bid processes, and then to cooperate with me with whatever I'm doing when it comes to some of the more innovative issues that we are doing as well.
Yeah, that's great advice. You can't manage what you don't measure, and so to actually have the data and look at it, it makes a big difference, especially when you're looking at much higher costs due to higher severity, as Dr. Pat was describing in her presentation, and I think you did too, Dr. Sachs. And a 2-month delay causes, just raises the mortality rate. Dr. Pat, geography is everything, and Dr. Sachs talked about the centers of excellence that are woefully few across, if you look at the whole United States, for the access. Tell us a little bit about the Community Oncology Alliance that actually fills in for a lot of the lack of access to the comprehensive.
Sure.
How that works with that.
It's a great question, Marianne. So I'll say that, healthcare in general, as everyone here knows, is a collaboration of many individuals. And I'll say, to David's point earlier, honestly starts with really good primary care, because the best thing that you can do to ensure a good outcome for cancer care is to diagnose it early. And that really nests in primary care. But also, care has to be accessible. You have to have it for patients in their communities. It has been a time of remarkable change in cancer care, where for many, even with advanced cancer, cancer is a chronic disease. I have in my practice, where I've practiced for 15 years, have many patients with metastatic breast cancer who have been alive and well and working, and employees in their jobs for 15 years. And so providing cancer care close to home, which is kind of the mission of community oncology, to provide great high quality cancer care close to home, both gives patients good outcomes from cancer, but also allows them to live their lives on their terms. Because not only do I want my patients to have a good outcome, but I want them to pick up their kids from soccer. I want them to be able to complete their job as an attorney. I want them to be at their dinner table as much as possible. And I think that's what really helps to preserve quality of life for cancer patients. So, I practice in Austin, Texas, but my practice has 210 sites of service across Texas. And that's in urban cities, but also in rural areas like Paris and Euless. And so I think about how we enhance care delivery to try to ensure that we have high quality cancer care in those communities. Now, I will say, so grateful for large cancer centers. I think that there's frequently a collaboration, especially if there is a need for access to clinical trials or other expertise. That oftentimes is a really useful collaboration. But great high quality cancer care close to home matters. In my community cancer clinic, we have over 70 clinical trials that are open for patients in community oncology. And that's not true at every practice, but I think that for most patients, being cared for in their home and supported in their life, it gives them the best possible outcome and usually allows them to stay in their jobs and allows them to be active in their families. And I think that will become even more the case as we continue to foster innovation in cancer care and see most patients with even advanced cancer live with it like a chronic illness, like diabetes or hypertension. Now, I'll say, Marianne, I'm a breast cancer specialist, so we've had a lot of innovation in breast care. We need it more in other cancers too, like in pancreas cancer and cholangiocarcinoma, other very difficult cancers where there hasn't been quite as much innovation and transition to the cancer being chronic in nature. But I think actually great community oncology care is the best answer for employers because it allows patients to continue to work and be active in their lives in addition to great high quality care. But again, it's a collaboration. We work with referring providers like primary care doctors. We work with major cancer centers.
Yeah, that seems like that would be for an employer, and I can't speak for all the employers, and David may weigh in on this, but it seems like the ideal model would be to have access, as Dr. Sachs was describing, to the major cancer centers if needed to go to something like that. But then to have this initial diagnosis, the ongoing, to have the community having it close to home and wherever your community is, like your practices, Dr. Pat, would be an ideal model. It's just that, one size doesn't fit all, but it sounds like if one were to put together a center of excellence, it would involve both sides of that, the Comprehensive Cancer Center, as well as the community access to your community alliance, for example.
And I'll say, Marianne, I think another really important point for employers to hear is it's not only just that one size doesn't fit all, but that cancer is such a life-changing event that patients, employees really need to feel comfortable with their path. And frequently that might mean that they get a second opinion from a disease-related expert, as opposed to someone that sees all cancer types. I won't say that that's always necessary because I don't believe that it is, but sometimes it can be helpful. It can be helpful both in making sure that the disease is managed optimally, and it can be helpful also in managing the anxiety and mental health of the patient and the wellness of their family, and them knowing that they have well-coordinated and advanced care.
Mary, if I may.
Go ahead, Dr. Sachs.
I'm so appreciative of what Dr. Pat just said. I concur with everything she mentioned, and I want to highlight something she also said in her talk, which is not to lose this opportunity of utilizing telemedicine more than we have. When we were in the height of COVID in the very beginning, when we really didn't know what to expect, the amount of telemedicine care, especially in some of the organizations that I had looked at and worked in previously, were verging on more than 90%. Now, obviously that wasn't going to be maintained and it's decreased, but hopefully we don't lose the importance and the learnings from that, because we can do so much more.
Indeed. Well, I just want to thank all three of you, Dr. Pat, Dr. Sachs, and David, for just an outstanding presentation. I imagine, well, I have a whole boatload of other questions or issues, and I'm glad you mentioned the telehealth, Dr. Sachs, because I think that's such an important, since COVID has become such a major thing, such a major role in employees' health care, the access to care. So Dr. Pat, you mentioned that as well. So with that, we're right on time as far as this session goes. And so thank you again for participating. This is outstanding. This session has been recorded, and we'll share that with those who registered afterwards. Before we sign off for today, and before I tell you about tomorrow, I wanted to show you a quick Access Hope video. I think this might be interesting to you. Ties in well with what we just talked about.
Thanks for joining me today. My name's Todd Sachs. I'm a surgeon and currently the Chief Medical Officer for Access Hope. In the United States, the percentage of people dying from cancer has fallen 27% in the last 25 years, thanks in part to ongoing cancer research and innovation. People are living a higher quality of life with cancer because there are fewer severe side effects when utilizing targeted therapies. These advances are not only meaningful, but essential, and these innovative treatments should be available to every person with cancer. One of the main reasons that is preventing people from accessing the latest and greatest in cancer care is because of geography, because of where people live. This map shows the location of National Cancer Institute cancer care centers. These medical facilities are renowned for their cancer treatment. In many cases, these are the facilities where the advanced therapies were discovered and tested and the guidelines were determined. But as you can see, large sections of the country do not have access to advanced care. This is where care disparities arise, when some have access to levels of care while others do not. Let's talk about Access Hope. I am so grateful to be part of this organization. It was founded to bring the best in cancer expertise to people, regardless of where they live. We don't want people to leave their local doctors. Instead, we strive to have our doctors who come from NCI designated comprehensive care centers to work with local doctors near you, to ensure our members will have access to the insights and learnings of some of the best cancer doctors in the world. Our goal is to help address quality of life concerns while ensuring cancer patients have the best outcomes.
Well, that just goes to show what we were just talking about, the coordination between the cancer centers in here.
If one of them gets a cancer diagnosis, they deserve the best cancer support anywhere, no matter where they are. Access Hope connects your employees and their treating oncologists to the latest advancements in cancer treatment from around the world. Add Access Hope to your employee benefits package. Access Hope, fighting cancer with everything we know.
Okay, I think that's it. With that, let me thank you for joining us today. This has been just a both sessions on the advanced primary care as well as the impact of COVID on delayed care and on employee health and healthcare costs. Tomorrow, we're going to come back again at the same time at 11:45 till 2:15 for 2 more sessions as part of our Texas Business Group on Health Regional Forums. Tomorrow we'll look at the quest for total health and well-being, tackling the obvious and the obscure. It's a 2-part session looking at COVID's connection to diabetes, type 2 diabetes, and related conditions, and some interesting data on different metro areas in Texas. Houston, Austin, San Antonio, Dallas as the main ones, followed by a really interesting discussion about managing the total person's health and well-being and how closely related obesity is to so many other conditions that people are experiencing, and especially during COVID, when we think about the COVID-20, the 20 pounds extra that a lot of us put on. This is related to multiple other conditions. We'll talk about that as well. The second session is follows that as final and last section is on value-driven pharmacy benefit strategies to curb costs and improve outcomes. Pharmacy benefit is run one of the highest cost parts of your healthcare overall spend. So especially with some of these really high dollar biologics and biosimilars. So we will talk a little bit about biosimilars' role in relationship to biologics, especially for cancer care treatment. So with that, I want to thank you all for staying with us today, being part of our regional forum, and be sure you tune in tomorrow. You'll have your Zoom link to get in. And again, the sessions have been recorded. They will be available to you afterwards. So thank you to all of you who participated for today, and come back tomorrow. We'll see you then. I know.